Delighted to have with us today Bertrand Balduc, who many of you know, of course, is a licensed pharmacist, University of Montreal grad, holds an MBA from HEC, and certified director of the Canadian Institute for Corporate Directors. He's the chairman of Galanova, a distributor of pharmaceutical products, and co-owner of Jean-Thèse et Balduc, pharmacist, a pharmacy specialized in compounding and sterile products. He's also the co-founder and board member of Steranova, a Canadian pharmaceutical sterile manufacturer and distributor. In his spare time, Mr. Balduc sits on the board of Prevtech Microbia and Green Shield Canada. He joined the board of L'Ordre des Pharmaciens de Québec in 2009 and became the president in 2014, re-elected in 2015 for a 4-year term. So please welcome Bertrand Balduc. We're delighted to have you with us. Thank you.
Merci beaucoup. Thank you. It's a pleasure for me to be here today. Talk about a very important topic for pharmacists and the entire Canadian population right now, the opioid crisis. I have a lot of slides, so I'll go pretty quickly, and I'll try to focus on the few key messages I have today. The first key message I have is, why is the situation less problematic in Quebec? The answer is, we don't really know. We'll have a few hypotheses about that, but we don't really know why we don't have the same magnitude of a problem. The other question, key message, is what are we doing to tackle the problem? Lots of things. What works best? We don't know either. We hope that what we do is working and will continue to work. And the third thing I want you to take away from this presentation is that we're trying really to work all together, physicians, pharmacists, dentists, nurses, health authorities, the police, everybody together, so that we don't get more death because of those very important things. Here you go. So I'll go very, very fast over the situation in Canada because you all know about it. But I'll make sure we spend a little bit more time on what we're doing in Quebec to tackle that. And I'll try to spend a little bit more time talking about our ALERT program, which I think is a key initiative we have in place that is not very well known outside the province. Number of deaths in 2016, as you can see, we were less affected in Quebec still. We had some. Seems like 17 was going better. This is for Quebec, at least that's 9 months only data, but it seems to decrease. And what we see in Quebec is that the percentage of death associated with fentanyl in particular are very low. And from what I actually learned is that for the first 3 months of 2018, it seems like we did not have a single death from illicit fentanyl use. We don't know why. Hopefully, the police is doing a very good job. Everybody else is as well, but we don't know why, but it seems to go pretty well. So hospital admission by province are also low. Are our street workers doing better? I don't know either. We don't have a real picture of why it's working, but certainly we have less problems than everywhere else. I won't talk much about the federal strategy. I think you've heard a lot about it before, and we participate in every event and any invitation we receive. We're there, whether it's the summit that happened late in 2016. We were involved with the College of Physicians of Quebec, and we signed an engagement to work with everybody else and to do our part, and we'll talk about that. And we certainly are in favor of all the regulation changes that are happening or about to happen, specifically with the low-dose codeine consultation. We don't think we really need those products, but if we do, we certainly could put them under prescription status. And the latest news about easing restrictions for physicians to prescribe methadone and eventually pharma-grade heroin or diacetylmorphine, as we prefer to call it, distinguish it from what we find in the street, and certainly also, and more importantly, the budget that goes with it, because regulations are nice, but a vision without financing is an hallucination. And we need money and funds to put people behind all those initiatives. I'm going to talk a little bit about opioid use in Quebec, and these numbers just came out yesterday on the INES website, and it talks about opioid use for RAMQ patients. And if you remember, RAMQ program in Quebec covers people on social welfare, elderlies above 65, and anybody who doesn't have a private insurance by his or her employer. So that's a significant portion of the population, about 45%, possibly people who use more opioids than your private insured people. But still, what we see is that the prevalence of usage is about one people out of 10 use an opioid at one point or another. That's 2016 data. And opioids are more used by women than men. And so that's important to notice as well, but not that by much. The other thing that's important to see is that there's a slight decrease. So between 2006 and 2016, we seem to use less opioids, which is certainly a good thing. Is this an urban problem or a region problem? And we tend to think that problem is in the big cities, but it's not actually. It's even worse the farther you go from Montreal, it's actually worse. So it's not only a city problem, and that's important to notice because people tend to think that, you're only going to find those users or dependent users in the big cities.
The more north you go, the better the rest.
Yeah, actually, yeah, the northern you go, the worse it is. This is very interesting. That's the opioid type prescribed in morphine equivalent, and as you can see there's different trends there. The first important trend is that codeine is going down, way down, which is a good thing, and that hydromorphone is going up. Oxycodone is going down. It went up for the first 5 years between 2006 and 16, but now it's starting to go back down. And morphine is going up, and fentanyl is pretty much stable, and it's slow. So we're not using as much fentanyl as other products, most probably because of its pharmaceutical form, only available in patches. And when you look at prescriptions for non-cancer patients, we see that most scripts are for short-term duration, which is what we want to see. We don't want to see it, or we want to see it only for the use for short term. Long-term users are very low, a low percentage of scripts, and obviously there are a lot of initiatives to decrease that, but still I think we're starting from a point that is already a good situation. So that's what's happening in Quebec right now. That's the latest news from actually yesterday. What are we doing? Obviously, the health ministry has an action plan, and it actually says do not share with anybody, but it's sold, so I'm sharing quite a few things with you guys. But still, 7 fronts where actions are going to be put, obviously trying to understand the situation, monitoring and surveillance. So what's happening with health professionals mainly, intervention to prevent and reduce events, information targeted to opioid users and non-users as well. So a lot of information and prevention at the general population, because the people who are not using those products today could be those who use it tomorrow. Professional practice optimization. We've seen that the situation seems to be good, could always be better. And we're working quite a bit on that as well. And I think the pharmacists can play a much larger role there. Improve addiction patient services, because for those who have the problem, we need to solve it. And it takes a lot of time, involvement, and work and care. And what can we learn? How can we study what we're doing to do better? And obviously, we'll see what we do. So a lot of things are going on to monitor the situation, especially about testing drugs in the streets. And our understanding is that the police is much harsher on people who play with people's life. So if you're a drug dealer and you're selling bad stuff or fentanyl, drugs that include fentanyl, the police will interact a little bit more with you and make sure you stop that. So seems like they're a bit more tolerant of what's happening if you're doing less problems, causing less problems than if you're playing with people's lives, which is normal. It's normal to, I guess, tolerate some level of activity, but because you get to know what's happening, and when you have a problem, then you see that it can be solved pretty quickly. Supervised injection sites have opened up in Quebec, a few in Montreal and Quebec City now. As you know, they need to be approved by Health Canada, something that they didn't want to do before, but now clearly this has an impact. And the naloxone distribution program is now in place in Quebec. We don't cover the nasal spray, but pretty much every pharmacy now can distribute and train people on naloxone, whether you are a patient or not, that you have a social health insurance number or not, that we know who you are or not, you have access to it.
The naloxone initiative, is it just particular to Quebec, or that's been?
We're actually behind. Ontario went much before us, and now they even have the nasal spray available for free. And obviously nasal spray is much more expensive, so Quebec didn't go for it yet. Will they go for that eventually? I don't know. But we used our influence on Health Canada along with all the other pharmacy colleges across Canada to get naloxone delisted from a prescription status to an OTC status, and now it works pretty well. And I think it shows that pharmacists, when we ask them to do something for public health, they can be extremely good and fast in implementing programs like that. This program was implemented in a number of weeks. And actually, planning was not so well done, so we had some back order problems for injectable naloxone, but the situation is now under control. So we're doing a good job at naloxone, and if you ask pharmacists to do something, they will do it. They get trained on it very fast, and they'll train people to use it. So same thing, we inform the population that naloxone is available to users, about the Good Samaritan changes in the law, and we still encourage people to bring back their old drugs or the unused drugs to pharmacies, and we're going to work even much more on those campaigns in the future. Same thing for the general population. Prescribing guidelines for opioids, we're going to make a lot we're going to put a lot of work to promote them and get pharmacists to get trained on that and apply them. The nice timing is that since April 1st, continuing education for pharmacists is now mandatory. So they're all afraid they won't be able to do their 20 hours for a year. So they're jumping on any opportunity for CME. And here you go. We have a very nice topic for them. Broaden access to methadone and Suboxone treatment. That means changing the regulations, but that's coming up. And pharmacists are going to have to follow suit on that. And also I'm mentioning special care for kids born from mother using opioids, because it still happens, unfortunately. It's not always available. We've talked about that. So it's a multiple intervention strategy. We're trying to work on all kinds of things: demand, overdoses, death, prevent death, illicit drug supply. That was in an article from the New York Times recently, where we try to show where we can work, and all the red circles is where we are trying to work. So education, community development. We're also working with people in prisons who take care of those patients, because obviously there are problems there. So if you work on demand and treatment, prisoners are here. Pre-trial diversion, we're going to put a lot of emphasis on that as well, working with Health Canada in inspecting our pharmacies and making sure that the pharmacist does not divert products, but also sometimes it's not the pharmacist, it's the staff. And the places where we see most diversion are not pharmacies, it's hospitals. And it's not always pharmacists or pharmacy staff. It can be inhalotherapists. We have inhalotherapists substituting products for patients that were under sedation to get those products for themselves. So reduced diversion, prescription monitoring, drug checking, surveillance. Syringe exchange programs as well are very important so that patients don't get sick and don't get stigmatized. We are working very, very closely in Quebec with the College of Physicians. We are working with them on a number of topics, including the abortion pill, for which the program is now in place. And as you know, in Quebec, the product is available from pharmacies, mostly, and not from physicians, although the patient always have the choice to get it from the physician or the pharmacist. That's her choice, and we want to make sure that's respected. But we're working with them on different things, and obviously the challenge is always to find the balance between pain control and dependence risk, or access and restrictions. So in our mind, we have to work with others all the time, and we are talking to those guys, and recently we actually met with the staff from neighborhood pharmacies, and we met with the College of Physicians. So that shows that we are not afraid to work with stakeholders, but also to work together in meeting stakeholders as well. So that's something that's very, very important. We want to make sure that what we can do respects our mission, but also our financial resources. As you know, the colleges the money comes from the members, and they want to make sure that it's well spent. And it is well spent for them, from their point of view, sometimes if we do things for them, but the mission is to protect the public first and foremost. So, and protecting the public is making sure pharmacists can do more in protecting the patients as well. So governance, advisory committees, pharmacists are very important, have a very important role on those, prevention, training, and monitoring and surveillance. So we have what I call an inter-college governance approach, including nurses and dentists. We often forget those guys, the dentists. They prescribe quite a bit of short-term opioids. Sometimes short-term for them is a bit medium-term for us. And they need to be better informed, and dentists are very, very easy to collaborate with. Usually, if a pharmacist tries to call a dentist, the relationship is always easier, or it's easier to get through than doctors sometimes. Our board of directors and executives at both colleges know themselves. We have a joint committee with the college, which includes board members from both organizations. And we have the same with nurses as well. So we talk to them on a regular basis. And we've talked about the campaigns to promote the safe drug return to pharmacies. We've talked about going a little bit harder on impact and stopping power, using campaigns that are going to sound and look like the Don't Drink and Drive campaigns, which work actually. And we're working with the Public Health Division at the Health Ministry on this. The prescribing guidelines, again, the 4 colleges work together. And we work together also with other colleges if need be. I was giving the example of the medical assistance in dying programs, where we work with the lawyers college. I don't know if you we call it the barreau in Quebec, the bar. And we worked with as well notaries and physicians and nurses and social workers who have their own college in Quebec as well. And we actually work with our professional insurance companies. Physicians are insured by the federal institution that's called Canadian Medical Insurance something. In our case, pharmacists in Quebec, we have our own insurance fund. So we work very closely with them to make sure that we decrease events and claims, obviously. We work closely with NAPRA, and our main, I think, objective is to get the federal government to recognize pharmacists as practitioners so that they can prescribe opioids, and by the brackets, I mean sometimes reduce, temper, adjust dosages. That would be a great help, and I think pharmacists would do an amazing job for patients on this. In many, many provinces, including Quebec, pharmacists now adjust dosages, and it's just nonsense that we can't do it for those classes of drugs. So we've done a lot, and our partners are pushing all in the same way, and I think it's pretty unanimous in Canada that this should happen as soon as possible. In terms of diversion, we're working very hard to get pharmacists to do a better job. I think they already do. They're very good already, but they can be better, and the goal is to have no diversion at all. And it's very difficult. Sometimes we get situations where we implement guidelines, doctors get better, patients get less product, they go to the street, police do a good job, product is not available in the street, pharmacies get robbed. So we get to the point where we have to decrease demand. And that's where social workers, street workers, and programs for people who are dependent are very, very important. Otherwise, we're caught in a catch-22 situation. We're working closely with the Controlled Substance Bureau. As you know, pharmacists are inspected by Health Canada. If they see something that worries them, they call us, and we get our own inspectors to make sure that things are better aligned. And we're working quite hard these days, and in the next, I would say, 2 years, to make sure pharmacists, what we call the circuit du médicament, or the drug distribution system, is optimized to avoid errors and certainly diversions as well. One thing that would be very important is that we get rid of those paper prescriptions, because paper prescriptions means falsified or false prescriptions. And we have this tool in Quebec called Dossier Santé Québec, which is getting better every day. It took a lot of time. It costed a lot of money. But on an everyday basis, pharmacists get on it and do things. And as you know, it's an opting out system in Quebec. If you're a patient and you don't want to be included, you have to ask for it. And if you're not included and you come to a pharmacy with a narcotic prescription, you're going to get some problems getting it, because it looks very suspicious. You don't opt out of the DSQ for a good reason usually. So we're working closely with the IT department of the Health Ministry, and hopefully very soon, I can't say when, we won't have any more those paper prescriptions. And add the coding to prescription status as well. We're working with an institution called INSPQ, the National Institute for Public Health in Quebec, to make sure that we study and we do some research of what we could do. And what we're going to do with them is ask for money, and I think hopefully we're going to get that, to study our ALERT program. And this is where I talk to you about our ALERT program in Quebec, which I think has a role and has some impact. We don't know how much, how, but it works. And this program was put in place in 1985. So that's 30, I wasn't a pharmacist in 85. I wasn't even a pharmacy student yet. So, and what it does, it helps patients with an abuse problem. When a pharmacist detects a problem, he talks to the patient and says, you want to get into the ALERT program. They say, what is this? Well, the ALERT program is going to force you to select a pharmacy. And you're going to get all your narcotic products from only one only pharmacy. And you're going to get your scripts from one doctor and only one doctor. And slowly but surely we'll work with you to decrease your dependency and make sure you use those products for the right reasons in the right way. That's the first part of the program. And the other thing is that you don't want to get into the program, well, you'll be blacklisted everywhere anyway. We're going to make sure that you won't have this easy access that you think. So it's the pharmacist initiative that always starts everything, and he calls the coordinator at L'Ordre des Pharmaciens and say, I have a problem with a patient. And I think it's an ALERT program patient. And the coordinator at the college is actually a legal investigator from the college. It has the power to investigate, call other pharmacists, and pharmacists anywhere are obliged to collaborate with the coordinator, which they obviously gladly do. So whether it's a new falsified or false pharmacy prescription, reasons that the pharmacist think there's multiple prescribers, you're going to tell the patient if the patient doesn't want to get on it and sign an engagement contract, we'll make sure that every pharmacy in the region and possibly in the entire province will know that this patient is under an alert. In my early days as a pharmacist, the alerts were sent by phone. So I was getting a phone from a colleague and had to phone 4 other colleagues and so on until the chain was all done. To the electronic emails and everything are getting better, and it goes very quickly. So it goes pretty fast. In a matter of minutes, if not a few hours, everybody everywhere will know about the problem, and the patient's going to be blacklisted. And what the pharmacist basically do, he makes up a file about the patient and puts alert on it, and the details of the alert, so that if the patient goes to another pharmacy, the profile will come up and the patient won't be able to get anything. So when do we do that? False or falsified prescriptions, stolen prescription pads, it still happens. And those patients are very creative in getting those. Drug abuse behaviors, and also we see a lot of photocopies of scripts. And photocopiers are very good today, including color photocopiers or printers, and that's it. So when a patient chooses to engage in the program, they'll do it, and then one day, hopefully, there'll be an end of control. That means the patient won't be under alert anymore. And that happens only when the pharmacists decide that it happens. It's not the choice of the patient to say, I don't want to be under an alert anymore. It's your pharmacist's decision to say, okay, I think you're okay, and I'll get you an end of control. And it happens, and hopefully it will happen more as good care is given. But it's very important to specify that's the pharmacist's judgment that goes into it. And if the doctor doesn't want the alert to stop, then it continues as well. If the patient say, I want to change pharmacist because you're too bad with me, the patient can change pharmacist, can change physician, but they cannot change everything. It can happen. So how long do you get under an alert? It can be very variable. For some patients, they've been on an alert, I guess, since 1985. But usually it's 2 years, or until you get an end of control notice. And that's your pharmacist's decision on it. And but usually patients stay on there for it. And those are some stats. So how many alerts do we get per year? About 1,200. That's pretty stable. And what products are the cause of those alerts? But fentanyl, as you can see, is not a major problem. We don't see abuse of fentanyl patches. What we see is hydromorphone and oxycodone as the main culprits, but not only narcotics from the opioid class, but also anxiolytics, sedatives, hypnotics, and like zopiclone is a very popular one. So, and antidepressants as well, because some people make bad uses of those. So that's the alert program. I just want to go back to that. You see 1,200 people on those. Are we saving those 1,200 people per year? Possibly not. Some of the patients would be in the previous slide statistics if this program wouldn't be in place, I'm sure. But how many of those, I don't know. And the INSPQ research study could give us more information about what works or what could be improved with the program as well. So we do a lot of training. I've talked about that, and we're going to use other colleges' programs as well. We're not the only people with good programs, for sure. We're working with other colleges. We are in contact with our 2 faculties of pharmacy to make sure that our undergrads are getting the right training as well, and that it's somehow standardized about them. But usually, when you get new things, universities are quite fast in getting that included in the programs. So when we did the expanded scope back in 2015, all the new graduates were already ready for it. Same for the abortion pill, the naloxone kits, it's now included in the program. So very, very fast our faculties react and adjust their programs. We said we would add dentists to our committee. That's done. We talked about the research program for the alert thing, and we are working with the government to change their access to information laws and regulations so that we have access to prescription data, more on the college physician side. And at OPQ, what we would like to have is access to buying and selling information. So what we want to monitor is what the pharmacist is buying on a regular basis in the trends. So if a pharmacy suddenly starts buying tons of hydromorphone, we want to know, and we want to go and pay a little visit to the guy and say, hey, how come you're buying more hydromorphone? And there might be a very good reason for it. There might be a change in the clientele profile. There might be starting to serve I don't know, a place where we have end-of-life care or whatever. But if there's a change, there needs to be a reason. And we need to be aware of that, not be on the reaction side for that. So in conclusion, I think people in Quebec are trying to work together to make sure that the crisis doesn't get worse and actually improves. We take the lead on some dossiers. Standard of practice, communications, training, and we're using, maximizing the use of our communication platforms for that. We are partnering. We're always open to partner with anybody who has good ideas about that, whether it's government institutions, pharmacy associations. One of the examples I wanted to mention is that we work with the Chain and Banner Association in Quebec. They've developed an opioid script validation algorithm that looks something like that. That's just the first page. And obviously, we're happy to work with them in promoting that. So the pharmacist has a standardized way of making sure that the opioid prescription that they get is valid and should be filled, and how the patient should be counseled and monitored afterwards. And we're trying to use our influence because a lot of times we don't have the power. We can only, I always say to pharmacists and pharmacy students, we're the order of pharmacists. We're not the order of anybody else. So we can only force pharmacists to do things or help them do things, but we can only influence others. So we're trying to use this influence that we have on the other stakeholders of this problem, including the DSQ, and hopefully that's going to work eventually on that. So that's what we do. Is it working? I guess it's somehow working. Does it have the impact that we would like? Possibly. Could it have more impact? Hopefully. Can we improve? Certainly. Can we work with everybody else in Canada? We are actually doing it, but we could do more for sure. Are we open to do more and better? Absolutely. Denis.
Question. Would the fact that there is less people out of the opioid crisis in Quebec, they explain that they are using other drugs more prevalently to compensate? Has there any study?
You see the alert stats? Antidepressants? Antidepressants are more used in Quebec. We would put cannabis scripts, you would see less use in Quebec. How come? I don't know. I don't know. There's some cultural prescribing practices in there. There's possibly a lot of factors involved. How come? Maybe we're doing better. Maybe we're just luckier. It's hard to touch but there's something. Because when you look at the situation, it's different.
Yeah, the other thing, in Quebec, typically we dispense pharmaceutical dispensing 30-day script. Is that the same thing across the country, where somebody would go out with 90 pills at a time, and that could be an advice?
My understanding is that the 90-day or 5 refills a year doesn't apply to narcotics anywhere.
Okay, so that
No,
would not explain it.
that's my understanding. And I think in Quebec, we don't always dispense 30 days of narcotics. Sometimes it's much less as well, yeah. Hopefully. Yeah.
Merci, Bertrand. Just a question about heroin and methadone. I don't know if you have any knowledge about this, but we often get these changes on a national basis through the government of Canada. You mentioned assisted dying, and we have medical use marijuana, which has been a challenge for many, many years since they made this decision. This latest one about heroin and methadone, it's great to have that federal decision, but it puts pressure then on the order and other licensing authorities around the patient care perspective. My understanding that the change is coming, but it's not just here yet. And what work have you guys done, or maybe the other licensing authorities, to build that safety net around? It's not just handing out more drugs, obviously, because these patients need additional and very much intensive type care. Do you have any thoughts or comments on what they-
Well, for heroin, we haven't done anything yet, that's for sure, because it's not available. And when any product becomes available, then usually you see action, and sometimes fast action. Cannabis is an example. We have dispensing guidelines for cannabis for hospitals, not for pharmacies. As you know, we recently took a public position in favor of medical cannabis distribution in pharmacies and only in pharmacies under certain circumstances, i.e. approved products by Health Canada or under the research protocol, such as Dr. Ware's. So the moment you're going to see a product approved, then obviously we'll produce a guideline pretty fast if need be. We already have methadone guidelines. Any pharmacy can dispense methadone. We're not too strict on how and what, i.e. using the API or the approved solutions. We usually prefer that pharmacists use one concentration of the solution or the API. Mostly it's more reimbursement factors that come into practice for that. But if we would have an approved heroin product, then we would move pretty fast on this. But technically, from a regulatory perspective, we don't really need to change any regulations, just guidelines and practice guidelines, yeah. Thank you.